so I'm dealing with a lost bag situation, so you get casual, Misha. I'm giving you a lecture. I have a purple shirt and a purple tie and all my like purple sarcoid awareness things that I usually do this talk in. So I'm sorry for the white, but it's very nice to be here and it's a great conference. And you really have, I know Kelly was talking about the group across the street, the American Association of Sarcoidosis and other granulomatous diseases, which is also a great group, but you really have like a lot of all-stars here, and so it's always nice to see the people who the FSR gets to come do these patient presentations. So I'm going to be talking about sarcoidosis from a dermatological perspective. And I'm in University of Pennsylvania, which is a little bit far from here. This is one of the few locations in the country, though, that there is a dermatologist who's interested in sarcoidosis or experienced in sarcoidosis specifically. Her name is Emily Keinbig, and she's here at Northwestern, and she is taking new patients. And so if there's someone who's been struggling or suffering or having some of the patient experiences that were highlighted this morning from the patient perspective of feeling like it's up to you to drive your doctor to do things, or that your doctor knows less about the disease than you do, Emily is actually a really wonderful dermatologist who's very experienced in treating skin sarcoid. So I have no real relevant conflicts when I'm going to talk about anything that's on here, just because I've been trying to get drug companies to be interested in developing medicines to treat patients with sarcoidosis. I'm going to have a picture-heavy presentation because I think one thing that's really important is that you guys really do know your body and your disease better than your doctors, and you have an integral voice in the care and diagnosis and treatment. And so, we talked from Elise about, how fatigue can drive treatment, or some patient symptoms or quality of life can drive treatment. And so it could be that someone has, what looks to their physician like just a few bumps on their skin. The doctor says, well, it's great, your 6-minute walk test looks wonderful, your pulmonary function test looks great. And people say, well, someone thinks I have a contagious disease, or I don't want to go swimming, or my grandson doesn't want to hug me, or at work it's awkward for me to introduce myself, or I just have some spots on my hand, but when I shake people's hands at work, it's really distracting and, for some people embarrassing and can be stigmatizing. And so I'm going to highlight what skin sarcoid can look like. But skin sarcoid in dermatology is held up as one of these diseases called a protean disease, so it can look like just about anything. And so I have a pretty low threshold to bring to your doctor's attention if you think there are new things developing on your skin, and especially if you think that they're developing in places that I'm going to highlight as common places for sarcoidosis. And so this is one morphology of sarcoidosis. This is called papules. And the actual terms don't really matter that much. You've seen pictures of the granulomas of sarcoidosis, and so sarcoid tends to form these granulomas. When you get granulomas in the skin, they tend to raise up the skin, and so you get a little bit of substance to the lesions that you'll see. And so this is a lady who has a lot of little bumps on her back, or a lot of little papules on her back. That has a good prognosis comparatively. This is a patient who has what's called lupus pernio, which was introduced earlier. This is pretty striking as far as severe facial sarcoidosis. This pattern is really important because there's not that many signs in sarcoidosis that tell you right off the bat what treatments you might need or what your prognosis is going to be. Patients who have this manifestation of sarcoidosis tend to have chronic, recalcitrant, or hard to treat sarcoidosis, are more likely to have upper airways, so like sinus involvement, or certain patterns of lung disease. And then this pattern of sarcoidosis really only responds to the TNF inhibitors. So you see these algorithms of treatments that are laid out, and there's a lot of thought that goes into them, but each patient is different. This is one of the manifestations of sarcoidosis that we know if you have this, the things on the front part of the algorithm are unlikely to be as helpful to you as some of the things on the back part of it. One of the other places we tend to see a lot of sarcoidosis, besides on the nose and the central face, is patients who have granulomas developing in or around their scars. And so this is someone who had a surgical scar on his hand, and then he developed these superficial spots. And I don't know if you can see, there's a little bit of swelling underneath, and so he has both surface sarcoidosis and some subcutaneous sarcoidosis. And so anytime we see someone is sent in for presumed sarcoidosis, we look at their face, and we look at the openings around the eyes and the nose and the mouth. We also ask about surgical scars, and then we also ask about tattoos. And so this is a carefully cropped tattoo, so it's indelicate to the company. The lady on the hood of the car is not saying something very nice. But this is illustrative because I work at Penn, and the pulmonologists know very well that patients can have skin sarcoid that can look like a lot of different things. And so when you hear about someone getting a brain biopsy or a mediastinoscopy or open lung biopsy to try to get tissue, you should remember that the skin is right there on the surface. And so really the skin is probably the second most commonly affected organ system. And so so if you're in a situation where people think you might have sarcoidosis and then they need to do a diagnostic test to find those granulomas, it's way easier to biopsy the skin than it is to biopsy one of the internal organs. And so we tell people they should have a really thorough exam. And a lot of pulmonologists are fairly good at this. A lot of dermatologists are slightly better at this. And so this is a patient who had what looked like hyaluronopathy. The presumption was that this was pulmonary sarcoidosis, but there were some atypical features, and so the pulmonologist walked him over to my clinic, and you can see within the tattoo, actually, all of these little bumps are little sarcoid papules hidden inside the tattoo. And so it was really easy to biopsy one of these, show sarcoidal granulomas, and then you have skin and radiologic signs or chest x-ray signs of lung disease, and then the patient can be comfortably diagnosed with sarcoidosis and then treated. Sometimes tattoo involvement is a little bit more striking, and so this is pretty exuberant. With treatment, the tattoo sarcoid went away, and you can see the ex-boyfriend's name, and so the sarcoid went away, but then the tattoo showed the difficult breakup, and so there's a little less of you can have a lot of different morphologies though, and it can be fairly subtle. So this is someone who has what's called subcutaneous sarcoidosis, or these lumps underneath the skin. And so you can see this looks very different than those lesions on the face or the lesions on the back, and this is not associated with tattoos or scars. There is some rare manifestations of sarcoidosis, and so this is graphic intense. I hope you guys are okay. These are all patients who have sarcoidosis and they're all suffering from their sarcoidosis. It is important to recognize what it can look like, because then you can help people get treated. And so this is someone who has ulcerative sarcoidosis, and this is a very uncommon presentation, but the fact that sarcoid can look so many different ways and present with so many different lesion types makes it really important to have in the forefront of your mind, if you're trying to establish a diagnosis, to remember that seeing a dermatologist or having a pulmonologist really closely look at whatever is on the skin can be important in helping make the diagnosis. You can also have what's called hypopigmented sarcoid, or loss of the normal pigment within the sarcoidosis. And then you can have thickened sarcoidosis or hyperkeratotic sarcoidosis. I'm going to pause here for just a second. So, there's a little bit of highlighting earlier on about the demographics. So, sarcoidosis, especially in this country, is a little bit more common in African American patients, and African American women in particular. So there are some studies that have shown that you can have increased rates of skin cancer in patients with sarcoidosis. And those have been done in a number of different populations. Skin cancer is not normally something that we worry about in people with relatively darker skin types, something you worry more about in patients who have lighter skin, Irish type complexion, red hair, freckles, blue eyes, blonde. But African American patients can get skin cancer. African American patients with sarcoidosis can get skin cancer. But you should be very careful if you are a dark skin patient or a dark skin family member who's told they have skin cancer. Because I've had 3 or 4 patients who had biopsies by a dermatologist that were interpreted as skin cancer, and then when they went back and cut out a deeper portion of that tissue, they found the granulomas on that deeper excision, or that second procedure. And you can see this is a picture of this lady's elbow, and there's kind of a vertical scar over on the right side of the image. And that's because this was biopsied, thought to be skin cancer, and then they cut it out, and it grew back, and she had another surgery because the presumption was it was recurrent skin cancer. And each time they saw granulomas, but they assumed it was a reaction to the biopsy or a reaction to the sutures. And really you should stop and think twice. It's pretty uncommon to get skin cancer in an African American patient. This is actually something called verrucous or hyperkeratotic sarcoidosis. And then it was touched on earlier that you can have another morphology or another type of skin lesion, and this is something called erythema nodosum. So erythema nodosum is inflammation in the fat, and this usually shows up on the anterior shins. And just like lupus pernio, or that really bad nose and cheek sarcoid means something, this is another pattern of inflammation that means something. So when patients have lupus, when patients have erythema nodosum like this, the inflammation of the fat, usually this is going to be a sign of something called Lofgren syndrome, or a sort of an acute, short-lived, very inflammatory form of sarcoid. You might have erythema nodosum and hyaluronopathy and maybe fever and joint involvement. Often patients will need to be supported through that, but these patients don't tend to have the chronic many-year course of the disease that you've heard about. And erythema nodosum usually shows up symmetrically on the anterior shins and can be tender when you touch them. So this is an example of what a biopsy of skin looks like, and you've seen a lot of biopsies from other organs shown, and they usually just show like one little granuloma, and that's because they're biopsying like the brain or the heart or the lung, and it's hard to get in there, and those are really important organs. The skin is an important organ also, but it's much easier to get there, and you have much more of it. And so it's actually pretty easy to take a big chunk, and then you can really establish the diagnosis fairly comfortably. So all of that pink, lighter pink color is the normal collagen, and all of those kind of purple-blue balls are the circular granulomas that are kind of filling up the the dermis here in that case. So we have a number of different algorithms that you've been shown very quickly. The only thing I want to say about cutaneous sarcoidosis, and this is somewhat simplified, you can sub in a lot of different newer treatments that have less evidence, but this is a general approach to skin sarcoid, and you will see that prednisone is not really on this, and that's because you've heard a lot about the side effects of prednisone. So there are some forms of skin sarcoid that are really devastating, and we will use prednisone to get more rapid disease control, like the ulcerative sarcoid patients. But there are a lot of treatments that fall in the topical or skin-directed group, or in that anti-inflammatory but not immunosuppressive group. And then there are some other traditional immunosuppressive drugs like methotrexate that you can use. And then for those really severe patients or the patients with lupus hernia, you might need to reach for one of those TNF inhibitors or the adalimumab, infliximab, Humira, Remicade option. And so I'm going to go through that a little bit more. And so this is where, if you are seeing primarily a pulmonologist, which makes a lot of sense for most patients with sarcoidosis, pulmonologists are amazingly good at treating the lungs. They're probably not as good as an experienced dermatologist at treating the skin. And so sometimes people might say, well, you have sarcoid, you have some bumps on your skin, we should give you more prednisone. And there's a logic to that, but it might not be the optimal way to balance improving the skin disease and limiting the side effects. And so there are all sorts of topical therapies that can be used. Usually they're steroid-based, but when you use topical steroids or injectable steroids, they have fewer side effects. And so this is someone who has fairly extensive tattoo sarcoidosis again, and then she was using high-potency topical steroids or something called clobetasol. And you can see that the sarcoid's gone away. There's also some lightening of the skin where she's been applying it, and that's one of the side effects of topical steroid use is you can get thinning or lightening of the skin. This is a patient I showed you before who had scar-associated sarcoidosis on the back of his hand, but also has that swelling, that kind of lump underneath the skin. And so with injections of steroids right into it, this kind of melted away, and he's had a very long or durable response, so we could say like a complete remission off of therapy. And so sometimes, again, with very little in the way of systemic side effects, very little in the way of affecting any other organs that are involved, you can focus on the skin and get some improvement. But the important things to know about this is if you're just putting something on the skin and you have some lung disease, putting a cream on the skin is not geared at helping lung disease. So we think about whether the skin needs a little bit extra in addition to what's going on systemically, or whether the skin is the most important or most important to the patient affected organ. Then there's some, we consider these like the low-risk immunosuppressive, or these are the low-risk systemic drugs or immunomodulatory drugs, because these classes of drugs don't weaken the immune system and generally have fewer side effects and require less monitoring than some of these stronger or systemic immunosuppressive drugs. And these are drugs that fall into these categories called anti-malarials or anti-inflammatory antibiotics. And the two most commonly used ones are hydroxychloroquine, which is called Plaquenil, and then either Doxycycline or Minocycline. And so this is one paper that came out relatively recently about 27 patients who were treated with Minocycline, and about 2/3 of them ended up responding to it. Minocycline is actually fairly effective. We use it for acne and rosacea and things like that. One of the issues in sarcoidosis is it can deposit some of the drug pigment in some of the sarcoid lesions. So sometimes the sarcoid will go away, but it'll leave little black spots in its place. Often we will instead use Doxycycline. So this is an example of a patient who already had a lot of discoloration from her sarcoidosis, and then through using Doxycycline in conjunction with some hydroxychloroquine, she had a very, very good response. There are a couple of studies of drugs that are not these anti-malarial drugs and are not these antibiotic drugs, and these are drugs called pentoxyphenylene, which is called Trentol, or Premolast, which is called Otezla. And these each have 1 or 2 studies, one for lung disease and one for skin disease. And again, about 2/3 of patients will respond to these, and these don't suppress the immune system. So there are some options before you get to immunosuppressive drugs. The immunosuppressive drugs can use prednisone, but it has a lot of side effects, and often for skin disease, when you take someone off of prednisone, the skin disease will end up coming right back. So we usually look for something we can use that's a little bit more efficacious long-term. So this is someone who has fairly extensive skin sarcoidosis, and again, Elise was talking about methotrexate being probably the most commonly or widely used non-steroid drug in general for most other sarcoidosis inflammation. And so we use methotrexate a fair amount for skin disease, and this is a patient who completely cleared after methotrexate. And methotrexate probably helps about 70–75% of people with skin sarcoidosis. But then those very severe patients that were talked about earlier by Elise, and again earlier by me with lupus hernia, those types of patients or patients who fail to improve on other treatments, those are the patients you should be thinking about using TNF inhibitors for. And the best data we have is for infliximab and maybe adalimumab. And so Alicia, the first paper from 2001 about that patient who had central facial sarcoidosis who responded to infliximab. This is one of the first patients who responded to adalimumab, and you can see fairly extensive little bumps on the skin. Other therapies hadn't helped. Adalimumab helped, and then she's smiling afterwards, which is how I now pose all of my patients. You have to look sad at your first visit, and then last visit. So this is the first patient I used a TNF inhibitor for, and on the left right now you can see that's not with maximal therapy, so that's on methotrexate and hydroxychloroquine and low-dose prednisone. And then we gave her, actually she just had one dose of adalimumab, and she came into the office crying, and I thought I had done something bad. And it turned out she was crying. She was so happy that she finally had something that melted her skin disease away, and then she was able to stop all of her other therapy. And that's a fairly common story. The problem is that these are, like most other things, not FDA approved for sarcoidosis, and these are fairly expensive medicines, so it's often a little bit of a struggle to get them approved for skin disease specifically. If you have neurosarcoid, sometimes it's easier to get some of the biologics covered by certain insurance companies. Some people have touched on that patients might have more than one disease. This is actually a patient who has inflammatory bowel disease, something called Crohn's disease and sarcoidosis, and so was able to qualify for her TNF inhibitor because of her inflammatory bowel disease. And you can see again, a fairly good response. That is her smiling, although it's not like a toothy smile, but she's pretty happy. I was going to try to leave, I know we're not supposed to take questions. I can't be here for the question session. Is there time for like one or two or?
One or two burning questions, noting that we will have some people who will stay with the panel who can also respond to having a dermatologist in the back room.
Yeah, so I have a question is the skin sarcoidosis versus psoriasis. So is it common, like it gets misdiagnosed?
So there's no like so the question was skin sarcoidosis for psoriasis. So because sarcoid can look like just about anything, and psoriasis is usually diagnosed just by looking at it, and patients, doctors will often not biopsy psoriasis. Yes, it can be misdiagnosed, and now there's about 3 studies that show patients with psoriasis have increased rates of sarcoidosis, and vice versa. So actually that African-American patient who'd been treated with methotrexate, he had both sarcoidosis and psoriasis. Both of them respond to methotrexate. Both of those diseases will also respond to TNF inhibitors. But that's why we say to have a fairly low threshold to do a biopsy, because if you do biopsy, it's very easy to distinguish this. Yeah, maybe last question, because I'm scared of Kelly and don't want to get
I have various questions. Years ago, when I had sarcoidosis lesions on the nose, the dermatologist actually gave me prednisone injections into each lesion, which was quite painful. That's not done anymore?
Yeah, no, that's spot on the back of that guy's hand. I went through it fairly quickly, but that was treated with injections. So injections work very well. They are very painful on the nose. They're not painful elsewhere. The nose is tough. But yes, it does work. It can get people clear or get people over the hump without any side effects too. So.
There's one more brief question in the middle, and then we'll move on.
It's really just a comment. I had psoriasis for many years, and then when I became sick and they diagnosed me with sarcoid, I don't know how long to have psoriasis. Is that common?
No.